Thank you. Good morning to everyone. Actually, I'm speaking on the role of medical officers in cancer management in Ghana. I will zero on the hospital where I work, Comfort Teaching Hospital. I'll give the background of Ghana statistics. This is Ghana. We have a population of about 29.4 million as at 2018. And our cancer incidence rate is around 0.25% per year. We have about 65,000 new cases per year, and approximately we are able to handle within the 3 institutions just 25. So we have a backlog or a shortfall of about 30,000 that don't come to us, and we still have to look for them. In terms of statistics, this is from, we can see the 3 main being cervix, breast, and prostate. And then if you look at our urban population over the years from 1960 all the way to 2018 is increasing steadily. In terms of the cases that we look at, this is just a distribution from the 3 centers. You could see for the female and the male, the various percentages of cancer being presented to us. And if you look, this is just for the new cases. We have about 2,400. And we look at the complete cases for the year, overall cancer cases, we have about 8,000. We have the trend, but we had the challenge. When I came, my computer crashed, so I have to quickly look at only 1 year. So we are presenting on 2017. In terms of infrastructure, this just spells out, which I know most of you are aware already, the role of medical officers in terms of diagnosis and treatment of patients. Our responsibility primarily is fixed on the technical aspects as well. So because of my time constraints, I won't go into this. This is a standard medical officer's role in any hospital. In terms of Kumasi, this is what we actually do per day. We do not work only in the oncology directorate. We also work in the radiology department. So with oncology, we are in charge of treatment planning. The CT setup, it's solely under the medical affairs and the RTT. Then we do our dosimetry. Mode room, unfortunately for us in Kumasi, we handle the mode room. We do all the mode room work. And then we assist in the simulation. We also assist our RTTs in the patient setup. When we get to the numbers, you understand why we do those things. And then in the radiology department, we handle the daily QC, weekly QC, all the QCs. And then we also do some work in the theaters because of their CM. Sometimes the clinician demand that we should be there to assist. And then we also teach the residents, oncologists. In terms of a milestone for radiotherapy establishment in Ghana, it dates back in the 1960 when we had equipment donated to us by the Canadian government, but there was no building to house it. So we lost it. It was a cupboard system. And then in 75, Ghana was ready with their drawing, but no equipment. But radiotherapy started in my center in 1992. That was when the Director General for Ghana Atomic Energy was a medical affairs, so he was very keen on that. So we started with brachytherapy in Kumasi, in Ghana. That was the first radiotherapy facility where we were using radium-226. Then in 93, Ghana Atomic Energy under a TC project initiated the need to have radiotherapy centers. So the Director General was a medical physicist. So that's why they were very keen on that. Then in 96, the building equipment were ready, but it was commissioned. That was our Accra project, was commissioned in 98. And then 2002, Kumasi came on board with a cobalt system, but it was commissioned in 2005. And 2011, the private sector came on board. So Ghana, we have 3 radiotherapy centers, 2 government and 1 private. That just shows a picture of the 1992, and it shows our gynecologist who was given training in the handling of the iridium-226. So you could see that it was manual loading. She has opened the safe to manually load the sources into the applicators. This is just the building of the 3 centers that we have. The Kolebu is on the very far left. Then Konfanoche is on the right, and the Sweden Ghana Medical Center is down there. In terms of equipment, just to give you a broad spectrum, all 3 centers currently, as I speak, we have a LINAC. Kolebu LINAC is yet to be commissioned, and hopefully by next month, they will start the commissioning process. Kumasi is yet to be fully installed and commissioned. I just spoke with Vivian. By August, the rest of the equipment needed, accessory will be provided and will be commissioned. Sweden, Ghana, they already have a LINAC. Cobalt, yes, Accra has a new one. Kumasi as old as 2004, so you could see, very old. And then Brachy, yes, Kumasi is having more Brachy now because we are still using the low dose rate. Now we just received the HDR iridium, and we're also going to get HDR cobalt. And then in terms of conventional simulator, yes, for Kumasi and Kolebu. And CT, yes, Kumasi yet to be installed, and the other facilities. MRI is down. Sorry that the thing is MRI, each one is having an MRI. So this is the new cobalt for Kolebu and the old cobalt for Konfanoche. I will show you how old it is. And these are LINACs. Kumasi on the left, the Sweden Ghana, which is operational on the right, and Kolebu down there. In terms of radiological facilities available to us in Kumasi, this is the spectrum. We have all this in Kumasi, so we don't have any challenge in having radiological background. Human resources and education, because medical physics plays a key role there. We have, for the spectrum of human resources, I brought in the 3 because I realized my colleague presented one which was very, very complete, so I have to augment what he has done. So this is the current statistics of personnel who are working in each center. Kumasi, we have 4 radiation oncologists. We have 5 medical physicists. RTT is a challenge, we have only 4. That's why the medical physicists have been supporting them the best way we can. The residents, we have 6, and oncology nurses, we have 5. In terms of education, we have a BSc physics with biomedical physics introduced into the government universities, which are 4. And that was since 1997, we've been teaching the background basic. We have the MPhil that was introduced somewhere in 2004, where you have 1-year didactic program, and then you do 1-year clinical research to publish your thesis, present your thesis. Then after that, you graduate from the university. Then you do 2 years internship in any of the 3 centers. But after your first year, you then write the Allied Health Professions Council that will give you the permission to practice. That's what we do. We also have a well-established training program for radiation oncologists, RTT, and oncology nurses. We've been actively involved, so I brought the statistics of not only local medical physicists, but we've been also handling foreigners as well. So you could see the breakdown, and therefore currently we have 11 medical physicists in the clinical environment, 10 of them are in research, and 9 are in the teaching profession. Various countries that we've been handling from 2011 to 2018 has been displayed over there, and it runs from Nigeria to all of them. In terms of equipment, we have various levels of equipment available to us at Confanochi, running from check source to anthropomorphic phantoms to chambers, and even to diagnostic radiology equipment. So we have those things that helps us to do that. The cost of treatment is a challenge for us. If you look at Kumasi, we charge the lowest, with the argument that patients cannot pay. So Accra, where we have the same facilities like Accra, they charge more than we do. And they charge before you are treated. You pay fully. Kumasi, we tried that and we were losing most of our patients. If you ask them to pay before you start, then forget it. So we start treatment, and as and when the patient can afford, they pay. Breast and cervix, it's on health insurance, where we are paying $4.58 per gray. So you could see that the challenge is how to maintain our equipment. We'll come to that. If you look at the private, they are charging economic rate to break even. That is the challenge we have in course of new treatment. We have a multidisciplinary tumor boards that we run for every patient. So we have the pediatric tumor board, breast tumor board, head and neck, and gynae oncology. Within the pediatric tumor board, we have all these disciplines. We meet Tuesdays, 8:30 every Tuesday, and it's mandatory that all the various disciplines are well represented. And the same applies with breast tumor board, but we do it with Henry Ford Health System, so it's a telemedicine. Thank you, I can break even. And then with head and neck, and then with gynae oncology, we do it with University of Michigan. So we have that collaborative work with them. This picture just shows you how the tumor board is being done, so you can see various disciplines all there to present their cases. We also have a cancer control program which was introduced into 2011, is there. 2012 to 2016 was when we presented that document. On our challenges, we have only 3 centers in the country, 729.4. So virtually 10 million to a machine. So that's quite a challenge. And then we had a $13.5 million loan facility to expand radiotherapy facilities in the 2 government hospitals. And that have been running from 2009 up to today. So challenged. We have a very expensive maintenance contract with the manufacturer. It's expensive for us because they are demanding $50,000 per year, whilst our patients are paying $4.5 per gray. You could imagine. Then our others is the traditional healers and our late presentation. So you could see our equipment, current equipment is this. This is the cobalt we use currently. The manufacturer doesn't support it anymore. So we locally manufacture things to keep it going. We maintain it ourselves. This is our low dose rate where we manufactured virtually everything to keep it going, because we need to keep our patients going. Our SIM is down as I speak because of maintenance contract. We have to raise $50,000 to sign with our manufacturer. Our cases are quite late. You could see them very late, as others have seen. And we just received 2 microselectron HDR systems from Radiating Hope to boost our system. So we want to thank them for such a bold step to help us, and we are very proud of that. So if everything goes well by 2018, we expect our Lena to come on board, HDR and the SPEC CT 2019, and our stimulator is already installed. I want to acknowledge all these people who have made my lecture possible. Thank you.